Hi doctors, how are you? Welcome to week 3 in pharmacology and the last week for pharmacology. 3 weeks is more than enough to study pharma. The drug-drug interaction is one of the main topics that you need to master for the AFK exam. It's not easy, and I think the way we think as a dentist is black or white. So it's either we have freezing or it's not frozen, we need to give more LA. But in pharma, the reality is not the same. In pharma, we have the gray zone. We have medication working over arteries and veins. We have medication reducing preload and reducing the afterload. Same for drug-drug interaction. This is normal. Like in your body, we have interaction between the drugs the patient are taking, the food he's using during the day, even the supplement. But all drug-drug interaction are treated equally? No, this is not the reality. Some medication has problem, some medication we can run away with it, some medication has contraindication with the whole family, some medication we can go away with some members in the family, some members we cannot use at all. And I think this is why most of us as a dentist, we think it's difficult. And in reality it's difficult, it's not easy. But let's try in this video, giving you 5 examples about the drug-drug interaction and more importantly, giving you a way of thinking about it. If you would like to read more about it, I did a blog over the website where we discuss about it and we can offer you a free PDF where you can see most important interaction. I'm not asking you to memorize it, I'm asking you to understand it and then apply it, and some medication at the end of the day you need to memorize. Let's start with our first question. Which antifungal agent is most likely to increase the level of warfarin through CYP to C9 inhibition? Fluconazole, nystatin, amphotericin B, terbinafine. Okay, before we go deep into this, let's try to understand this family. So this family is so scary. It has a lot of members. Not all members are equally important. Some which is related to metabolism of a lot of medication, and some medication are very important or very dangerous, like codeine, oxycodone, methadone, fentanyl, like the 3A4 or 2D6, and the other medication, the other enzyme here. So I would think these 5 enzymes are the most important when it comes to inhibition, inducer, when it comes to drug-drug interaction. I'm not asking you to memorize all this, but you should have a system where you are going to apply this system for the question. You need to understand the medication, mode of action, is it enzyme inducer, is it enzyme inhibitor, and then think about the interaction with other medication. To memorize all this is very difficult. So I tried to share a mnemonic where it's come to be easier for you. Now in Calgary, we have ice everywhere. You drive this way and you have accident in this way, so you are late for your appointment. So busy street, grab GPS. In this case, I would strongly recommend in such condition to use GPS all the time. As you can see, it can save you on the road and even save you in the enzyme inducer. Busy street, B and S, barbiturates, St. John's wort, which is like a herb some patients are using, and then crab, GPS, CRAP-GPS. Carbamazepine, rifampicin, alcohol, which is chronic, not the acute one, phenytoin, gracefulvine, which is related to the statin related to hyperlipidemia, phenobarbital, and sulfonylurea, which is related to diabetes type 2. These are medication which is considered enzyme induced. Easily you can see questions asking this enzyme inducer, this enzyme inhibitor, or sometimes it's getting more complicated. You remember during COVID when everyone is staying at home, so we can make a website which we can call sickfaces.com to collect all our sick faces, to put it over this website to be having this medication that again you need to memorize. Memorizing this medication is very, very important because trust me, it can save you a lot of questions and can give you the foundation where you can apply for that later and move you with confidence through the question. Please do not memorize a mnemonic and then forget the name of medication, because sometimes like sick faces, what is this F stand for and you don't know, or crab GPS and you don't know what's R standing for. So please understand this and remember the medication. So let's see the basic knowledge here. So the basic knowledge, if the medication is enzyme induced, what's going to happen? Let's give it just a number. So think about CYP2D6 and we have some enzyme induced, so like phenytoin. So this enzyme will be more. Think about it, it has 100 units. So it go to the liver, asking liver to give me more of this 100 units. Okay, so this 100 becoming 200. This 100 is responsible for cutting down or metabolizing some other medication inside your bloodstream. What do you think will happen to the other medication When this 100 become 200, amazing, the level of drug is metabolized is going to be reduced. So if it comes to be medication which have narrow therapeutic index like warfarin, lithium, digoxin, phenytoin, okay, so now we have problem. With other medication, it can go even unnoticed for most of the patient. But for this kind of medication, no, the patient will notice this and it will be difficult for this patient. So this enzyme inducer, increasing the number, so it metabolizes the other medication faster. So what you are going to do, you need to increase the dose of the other medication. You need to increase the dose of the other medication. I used to summarize it this way. Enzyme inducer, we induce the dose of the other medication. Inducer, induce, increase the dose of the other medication. On the other side, enzyme inhibitor, so this 100 is becoming to be 50. So 50 responsible to break down or metabolize warfarin. So warfarin will act like crazy inside the bloodstream, will make your blood becoming more watery, making the INR increase, so it's not working, not effective, so this patient might develop at the end of the day stroke, CVA, myocardial infarction, because the warfarin is not working. In this case, what we need to do, enzyme inhibitor, we need to reduce the dose of warfarin. We need to inhibit, we need to reduce the dose of warfarin. So here, this is the story, and this is how you should think about it. Next 5 questions, we'll just break it down. If you don't catch the concept here, stop, listen again, because moving forward, if you apply it like physics, it will be easy. If you don't follow this one, it will become very difficult for you. So let's see this question again. So we have warfarin, which is a vitamin K antagonist composed of 2 enteromeres, S-warfarin and R-warfarin. The S-warfarin, which is more potent, primarily metabolized by the CYP2C9, and the other one metabolized by the CYP1A2 and 3A4. Fluconazole, on the other hand, is a triazole antifungal, which is potent inhibitor of the CYP2C9. So we have here 2 medications working over the same enzyme, one which is inhibitor, and the other one which is primarily metabolized by this one, which is the warfarin. So what's going to happen here? When co-administration together, the CYP2C9 inhibition reduce hepatic metabolism of S-warfarin, which increase the plasma warfarin concentration, which lead to increase in INR because the patient blood will become more watery, which increase the risk of bleeding for this patient. So azole antifungal, especially fluconazole and voriconazole, significantly potentiate warfarin via CYP2C9 inhibition. Let's see our other option. For nystatin, not systematically absorbed, so topical. No, nystatin, we don't give it like systematically. We give it as topical, even if patient has fungal infection in his throat. In this case, we ask him to swallow. Otherwise, he can spit it after this. Amphotericin B has nothing to do with CYP. Terpafine, which is the weak CYP2D6 inhibitor. Yes, it has effect, but minimal effect over that. So, antifungal agent most likely increase the level of warfarin through inhibition will be fluconazole. Okay, hopefully that is easy, and let's apply more for the next few questions. Second question for tonight. A patient stabilized on phenytoin develops atrial fibrillation and is started on amiodarone. 2 weeks later, he develops nystagmus and ataxia. What is the most likely mechanism of this interaction? So you have patient taking medication to control his condition, and then he starts a new medication, ending up by some sign and symptoms which is aggressive. I will explain about this one. I hope you can understand the meaning of those. Induction of the CYP3A4, increasing phenytoin metabolism, inhibition of CYP2C9, reducing phenytoin clearance, increased renal excretion of phenytoin, displacement of phenytoin from albumin without affecting the total level. Again, let's break down the 2 medications, how does it work, and then think about it and apply it to the liver enzyme. Phenytoin, anti-epileptic drug characterized by narrow therapeutic index, high plasma protein binding, and non-linear, which is zero order pharmacokinetics at higher concentration. So most of the medication is reduced by half of the dose every half-life, but this zero order is reduced by constant amount. So for other medication, 100 become as 50. After one more half-life, it will become as 25. Amazing. This zero order, it's 100, we reduce 20. So 100 will be 80. 80, we reduce 20, it will be 60. And 60, we reduce 20, it will be 40. So you can see constant number. It's not like the other medication. Hepatic metabolism via CYP2C9, which is major, and we have 2C19. Amiodarone is a potent antiarrhythmic that acts on CYP450, is specifically inhibitor for 2C9, 2C19, and 3A4. So what's going to happen for this patient? When you combine it together, you have inhibition for the 2C9. Hepatic metabolism of phenytoin decrease. So plasma phenytoin concentration rises. So toxicity developed for this patient. And the patient here has this sign of toxicity, phenytoin toxicity. Nystagmus, which is early sign, ataxia, diplopia, and CNS depression. So the key principle for this kind of interaction, phenytoin exhibit capacity limited metabolism. Even a small decrease in clearance can cause disproportionate increase in the serum concentration because it's highly bounded to albumin. So once you let it stay more, it will end up by toxicity for some patients. So the answer here will be B, CEP2C9 inhibition, because this will increase the phenytoin level, which is toxicity. Let's see the other option. CEP3A4 induction, no, this will decrease the level, so this reduces phenytoin concentration, so unlikely this patient will develop signs of toxicity. C, increased renal excretion, again, this will decrease the serum level away from toxicity. Protein displacement only, this will transient increase in the free drug, does not explain sustained toxicity even after 2 weeks of this one. So question is slightly tricky because here is not direct asking, he's giving you the signs and symptoms of phenytoin toxicity. So you should connect the dots together and then you can reach your final answer. One more question. I know it's difficult, but like with breaking down of the information for each medication, your life will become way easier. Third question. A patient on oral contraceptive become pregnant after starting carbamazepine for seizure control. What is most likely explanation? So I'm telling you here, the patient is using oral contraceptive and start using carbamazepine, which end up by being pregnant. So this oral contraceptive was not working. So what is the reason? Inhibition of estrogen metabolism, induction of hepatic CEP3A4, increasing estrogen clearance, reduced enterohepatic circulation of progesterone, or increased protein binding of estrogen. Let's see. So let's break it down. So oral contraceptive contain ethanol, estradiol, and a progestin, both of which are metabolized in the liver by CEP3A4. Nice. Carbamazepine is inducer. Carbamazepine is inducer of hepatic macrosomal enzyme, particularly 3A4 and 2C9. So we have medication which is metabolized by this one. The other medication increase. So I think now you understand the application of this inducer inhibitor. So enzyme induction leads to increased hepatic metabolism of this medication, reduced plasma hormonal concentration, loss of ovulation suppression, contraceptive failure, which is not working. So strong enzyme inducer like carba, phenytoin, rifampin, phenobarbital decrease efficacy of oral contraceptive by accelerating estrogen metabolism. This is a classic pharmacokinetic interaction involving enzyme induction, not inhibition. So going back to the option here, induction of hepatic CEP3A4, increasing estrogen clearance. If you remember just a few minutes ago, I told you induction, we increase the dose of the victim here. Let's call it the victim. The other medication will be the victim medication. One more question. Question number 4. Concurrent use of phenelzylene, which is Nardil. So in your exam, usually they don't give this medication. If they give like Tylenol 3, acetaminophen, and codeine, because they should give you the generic name. Ammonoamine oxidase inhibitor, MAO, with which agent may precipitate serotonin syndrome. So concurrent use of phenelzylene and MAO, with which agent may precipitate serotonin syndrome. Codeine, tramadol, ibuprofen, propranolol. So just try to break it down. Codeine is opioids. Tramadol, this is pure opioids or natural opioids. Tramadol is synthetic. Ibuprofen, NSAIDs, COX-1, COX-2 inhibitor. Propranolol, here is related to beta blocker, non-selective beta blocker. So let's try to break it down. Phenelzylene is irreversible non-selective monoamine oxide inhibitor, MAO inhibitor, that inhibit MAO-A and MAO-B. When you inhibit the inhibitor, let's just break it down because initially it's intimidating, but once you break it down, it becomes easier. So here we have MAO. This MAO is responsible for breaking down the neurotransmitter in the synapse. If I give medication inhibiting the inhibitor, What do you think will happen to serotonin and norepinephrine and dopamine level? Amazing, it will increase. So MAO is responsible to break down the neurotransmitter. I give MAO inhibitor, like acetylcholine esterase inhibitor. So I am inhibiting the inhibitor, so the other one will flourish, which is serotonin, norepinephrine, and dopamine. So blocking those will lead to increased synaptic monoamine concentration, which is serotonin, dopamine, and norepinephrine. This is for the first medication. Let's see the other medication. Tramadol is an atypical opioid that has dual mechanism. Weak MAO opioid receptor agonist inhibit reuptake of serotonin and norepinephrine. Oh, so we have here interaction which is coming from two medication ending up by the same end result. Inhibit the reuptake of serotonin, and we have the other one inhibit the reuptake. So what we are going to end up, MAO inhibition, decrease serotonin degradation. With tramadol, increased serotonin release and decreased reuptake. Excessive serotonergic activity, serotonin syndrome developed for this patient. Clinical feature of serotonin syndrome: hyperthermia, hyperreflexia, myoclonus, agitation, autonomic instability. So combination of MAO with this SSRI, SNRI, tramadol, isoniazid, or meperidine significantly increase the risk of serotonin toxicity. Let's go back to the option here. Tramadol, serotonin reuptake inhibition, which is the correct answer. Codeine, pure opioid agonist. We don't have a specific significant serotonin action here, so it's not like huge interaction. Ibuprofen, NSAIDs, prostaglandin, nothing. Propranolol, beta blocker, and has no serotonin effect. So this will be leading to tramadol to be the correct answer. I hope now you can understand how we can apply. So most importantly, memorize the medication, enzyme inducer, enzyme inhibitor, then do the application for this one, understand it, and try to do it. And in our full course, we have a specific lecture to discuss about it, and we did go through the textbook giving you the tables one by one. This table discussing about this medication, what you need for avoid, what you need to with caution, what you need to reduce, and what is okay, with all the medication you can think about related to the AFK exam. Last question for tonight. A patient with hypertension controlled on losartan is started on a spironolactone for heart failure. So losartan, this tan is related to ARBs, which is medication to control hypertension. Same time, patient has congestive heart failure, so we add a spironolactone, which is other diuretics ending to deal with the heart failure the patient has. 1 week later, laboratory result reveal hyperkalemia. Okay, what is the reason for this one? What mechanism explain this interaction? Increased aldosterone secretion, dual inhibition of potassium excretion, increased renal potassium filtration, enhanced sodium reabsorption. Again, break down all the medication. Losartan, angiotensin II receptor blocker, which is ARB, block AT1 receptor, which is going to decrease aldosterone secretion. So because we have renin from kidney, angiotensin I from liver, together in lung become angiotensin II. This angiotensin II is working to get more aldosterone, do vasoconstriction, more water retention, increasing blood pressure. So losartan is acting over this angiotensin II receptor to block it. So when it block, it decreases the aldosterone secretion, which is going also to reduce sodium reabsorption from the kidney and decrease potassium excretion. So we are going to increase the potassium for this patient. Okay. We are going to increase the potassium inside the patient body. So read it carefully. Decrease potassium excretion. So potassium, instead of going out from the nephron and the collecting duct, is staying inside the oral, inside the kidney, and inside the bloodstream. Let's see spironolactone. Spironolactone is a potassium-sparing diuretic that antagonizes aldosterone receptor in the collecting duct and the distal port, the final port of the distal tubules, which is going to decrease sodium reabsorption, same, decrease potassium secretion, again, decrease potassium secretion, and here we have decreased potassium excretion. So what's going to happen for this patient when he used to medication? Losartan decrease aldosterone, spironolactone block aldosterone action. So potassium excretion in the distal tubules and the collecting duct is significantly reduced. Serum potassium rises, ending up by hyperkalemia. Just knowing the meaning of hyperkalemia will save you a lot, because hyperkalemia means increase in the amount of potassium inside the bloodstream. So combination of RAS, an ACE inhibitor or ARBs together with potassium sparing diuretics markedly increase risk of hyperkalemia, especially if the patient has problem in his kidney and renal impairment. Let's see the other option. Increase aldosterone. So increased aldosterone will lead to more potassium excretion, opposite to what happened in this patient. Increased potassium filtration will increase the potassium loss. Again, not hyperkalemia, it will be hypokalemia. Enhanced sodium reabsorption linked to aldosterone action. These drugs reduce sodium reabsorption, not enhanced sodium reabsorption. So at the end of the day, the reason for this, dual inhibition of potassium excretion. Yes, I know tonight's lecture wasn't that easy, but again, I don't want you to get intimidated by this. And at the same time, I used to do this a lot, but it's not working. Oh, let's go this table to memorize it. No, this is not how it works. You memorize everything today, after 1 week, you remember nothing. What I would love you to start with, understand the action, inducer, we induce, increase the dose of the like victim drugs, inhibitor, we reduce, inhibit the dose of the victim drugs. And you should memorize enzyme inducer, enzyme inhibitor, the scrap GPS, and sickfaces.com. So you memorize these and then you apply. After that, go to memorize. You can break it down. In our lecture, we break it down for antibiotic. This is the medication. For analgesics, for like diuretics, for hypertension medication, for all the medication, we have a specific table for everything. This, at this point, yes, you can memorize in a vertical dimension. I'm not asking you to memorize antibiotic today and ignore everything else. No, you're going to memorize even 2 or 3 categories from antibiotic, 2 or 3 categories from NSAIDs. Tomorrow, you add more for diuretics. After tomorrow, for SSRI. And then at the weekend, you memorize everything and add more information. This way, you let your eye go through the tables again and again and again. Repetition is your key and your way for this annoying and sadly high yield topic for your AFK exam. If you would like to get access for this one, I will leave you a link in the description. You can click, let your email staying in our page, and then I will send you email with this PDF. See you next week with LA. Pharma is done. You don't need to study pharma again. See you next week.